I invite Dr. Ashok Rajgopal to take his place on the dais. He would be talking about 3 decades of joint replacement. Dr. Ashok Rajgopal is the chairman and ex-director of this group of hospitals. He has more than 30 years of experience in arthroplasty and several publications to his credit. An honor to have you here, sir.
Thank you very much. Good afternoon. I want to thank Ram and Kailash for their very kind invitation to this wonderful city. And I feel it an honor to be here. So what I'm going to speak in the next 20 minutes is anecdotal. So it's not really full of references and so on, but it's really an example of my trip through 30 years of practice. So I started my first total knee replacement on the 25th of April, 87. It was a bilateral. It took me close to about 6 hours. We had limited instruments and we were very short on choices of implants. In fact, I only had 2 implants, one on the femur side, one height of the tibia, and we had unautoclaved femoral implants which we had to autoclave. System I used at that point in time was the Freeman-Samuelson knee, and the only option at that point was an uncemented option. The second knee we did some 6 months later, and that took about a couple of hours less. Initially, the instruments were few and far between, so I managed to scavenge some of the original instruments and actually got a very skilled carpenter to make these out of a teak wood, and the way we sterilized it we did some core biopsies and sent them for sterilization and to cultures to make sure that these were adequate. And we did the next 7 of these bilateral procedures using these wooden blocks made by the carpenter. And we started doing bilaterals at that point in time because it was so difficult for us to access implants and instruments, and availability of the implants was really a bit of a challenge. So typically, I got this really lovely video which explores the virtues of exactly what we went through. This is exactly what knee replacement was like in 1987.
Shaping up to be a rough commute out there today. Watch for an accident on the 101 near Sherman Way. And we're just getting word that the 405 southbound has been shut down completely. It's like some sort of police activity. It's kind of cleared for a 2-mile stretch from the 118 all the way up to Victory. As soon as we get more information, we'll let you know. But in the meantime, we'll get you through with another 40 minutes of your favorite hits on KCTV.
So typically this is how we felt when we were doing total knee replacement in the late 80s. And the best part is yet to come. So at that point in time, the implants that we had available was the duocondylar knees, the constrained knees, the geometric knees. So I really grew up on a diet of these implants. And then when we got the IB posterior stabilized, we thought we were very, very privileged at that point in time. The other options that we had was the Freeman-Samuelson and the Miller-Galante 1, and the FS and the MG had cementless options. So at that point in time, even the access accessibility of cement was really pretty much difficult, so we went to an uncemented mode. Patellar buttons were really unknown, which sort of stayed with me right through my career, so even today we do not resurface the patella, very similar to what Vijay was talking about. Costs were all pervasive, and at that point in time when I told one of my patients the cost of the implant for his wife, he said for that kind of price he could get another wife rather than get her knees changed. So we did a very small number of knees, and that time when we did 14 in a month, it was a huge cause for celebration. These were examples of some of my earliest knees, some 20, 24 years done previously. So I shifted over to the Miller-Galante system in '89, stayed with that technology till about 96, 97 when we moved over to the cemented school. So we went from the MG1 to the MG2. And remarkably, our 10-year survivorship of cementless knees was 97%, and our 15-year survivorship was 93%. When we look at the interface breakdown or meltdown, the survivorship was actually 100%. Most of these knees were really revised for osteolysis, and this basically re-established my faith in the cementless philosophy. 3 people who influenced my career. I scrubbed with the great 1983, doing my MCH with John Charnley. My mentor, my guru was my consultant in Liverpool, Mr. Graham Hayes, and I spent 6 weeks with John Insel in 1999-2000. And from them I learned that to be uncompromising on principles and exacting in the outcomes. From John Insel, I learned that knee replacement surgery was really a soft tissue procedure, and guiding principles had to be followed no matter what implant was used. And he was rather disappointed when at the tail end of my stay with him, he realized I was a CR surgeon. So from the very early days, I grew up on a diet of CR knees primarily because we did not have access to PS knees. And pretty much I stayed with that. When I used to initially present, I was the object of a fair amount of criticism and ridicule, but I continued on that lonely path. Typically, the example is something like this, and what sort of an implant would you use for these kind of rather horrific deformities? So the path we chose that we stuck with over the years was that we would continue with doing cruciate retaining knees for these rather severe deformities. And now, fortunately, and thank God for that, the debate between CR and PS has been given up. Otherwise, 10 years back, every symposium had a cruciate retaining versus PS, cemented versus cementless, patellar button versus no patellar resurfacing. Traditionally, it has been said that the cruciate retaining knee works for minimally deformed knees. PS is the workhorse, and while I accept that fact, you can do the CR knees in pretty severe and horrific deformities. And what's important, certainly in our experience over the last 25 odd years, is that function does not deteriorate over time, and so our survivorship at 15 years with the CR knee is 92%. So our stand currently is that we can correct practically all deformities of the knee with using a CR knee, and in our own consecutive series of almost 25,000 total knee replacements, almost 94% of these are CR knees, and only in a small proportion of the others was a PS implant used. This is an example of an ankylosed knee, bony ankylosed knee, where we used a CR type of an implant, a severe valgus up to 40 degrees, a fixed valgus, again where a CR implant was used, high tibial osteotomy, a patelectomized knee, gross varus subluxation. These are all long-term outcomes, 13, 14, 15 years. Patients with extra-articular deformities again lend themselves very adequately to these options. We did histopath studies from some of these severe deformities, and we found there was a normal collagen and proprioceptive receptors in almost 79%, and we've published this in the journal. A classic example, this is a patient who we did a CR knee 12 years ago, had a periprosthetic fracture that required a revision, and you can see over here that those are the two strands of your PCL, and you can see the same almost 12, 13 years ago, which has even survived the periprosthetic impact. But with every modular implant, with everything, you learn a lesson. So the first lesson that we learned was that do all new factors predict success? Modularity was introduced to make surgery easy for all of us, to give flexibility, but it opened the need to a new mode of failure, which is osteolysis. And here is a classic example of a huge area of osteolysis that we are seeing, fortunately not now, but in that generation in the mid-90s to early 2000, particularly in the cementless option, we saw a lot of this. And here is really the proof of the pudding. This is my first knee that I implanted 30 years ago. This is a cemented all polytibia, and you can see there's virtually no demarcation. These x-rays were done only about a couple of weeks ago, and this is still absolutely adequate. Unresurfaced patella, both components uncemented, all poly, no demarcation. Patient has 145 degrees of knee flexion. You want to extend that, maybe this is taking this one step too far, but we can use the CR knees in revision situations also, particularly where you can distinguish between true ligament insufficiency and pseudo-laxity, where there is a subsidence of the tibial implant because of bone loss. So you need to differentiate between ligament competence and bone loss, and revision with an unconstrained prosthesis requires competent and balanced ligaments. Classic example of this patient who had a CR knee which failed because of loosening of the tibial implant, and we treated this almost 15 years ago using a constrained anterior constrained CR type of an implant. When we started doing bilaterals, again, that was the focus of a lot of criticism for us, but pretty much the reason we did it was for reasons, as I said, the implants were hard to get. The patients that came to us at that stage were really very severely deformed, and today I think it is almost the dogma, the rule, that most of us in this room would do one-stage bilaterals in the surgically fit patient. So our current practice is to offer bilaterals for all patients who are 75 and lower. Over 75, we do not do them. We do them as a staged procedure. And if patients have obviously any cardiac or any medical comorbidities, we take a staged approach. And this is our outcome, and we compared this to the outcomes of Tom Skulko. The only differential here is that we had 0.3% of fatal P in our series, virtually as compared to none from the HSS group, but you can see the cohort of patients. This is almost 10 times a larger cohort. Are all developments good? And I've pretty much been a part, or at least been witness to, a lot of things that happen. Not every new product that comes into the market from the surgical industry really is a plus or a positive. And in my own lifetime, I saw two absolute disasters. We had the carbon impregnated polyethylene, and this caused catastrophic osteolysis and failure. And the second was the so-called minimally invasive MIS, both hip and knee surgery. And these were two absolute abject disasters. And if you Google search MIS quad sparing knee, you get something like 750,000 hits on the kind of complications. The same thing happened with hips as well. But then there was the other side of the thing. There is new technology, some of which is absolutely magnificent. A standout material that was available was the trabecular metal options in terms of cones, distal augments, and these were fillers, and they have evolved over the last about 10 to 12 years, and as a great way to modify and handle bone loss. Here is the appropriate use of technology. A patient who had a very thin patella, we used a TM button, and we were able to reconstitute the extensor expansion. Here is an example of a cone and offset stem, and we were able to replenish and obtain the distal joint line. We also have the choice of using monoblock uncemented tibias, which we are doing increasingly now. And this is one of our patients at almost 8 years. And here's a patient who's almost 9 years out to length, almost 104 months, and has done exceedingly well. You can also extend these indications in terms of difficult salvage situations. This was a patient who had about 2 or 3 previous revisions, some indigenous implant, huge amount of bone loss. So we had to address the issue of addressing the distal bone loss, restoring the joint line level, and the patella which was dislocated. So we used a stacked cone and with stems, and we managed to get the patella back where it belonged. Going beyond, we have the minimal implant, which is the unicompartment. There was some talk about that in terms of the Oxford, so there are both fixed and mobile bearing. We won't go into this. And then you have the megaprosthesis that we use a lot in terms of tumor resections and so on, and distal bone loss, which are massive. The other thing that came and to some extent went and then came back again is the patient-specific instrumentation, the options. And this was the new mantra. This was actually introduced by Emmanuel Thinport from Brussels. And interesting concept, it has undergone a radical sea change. But the interesting thing is, even in the hand of their developers, there's a 38% conversion rate. And the most important thing is, it does not give you a guide to rotation, which is the key to a successful arthroplasty. In terms of navigation, I mean, this also saw a surge. Today pretty much it's almost on the decline. And in a lot of these situations, these are articles from 2008 from one of the great proponents of the navigation system. And you can see over here, the dictum that comes out of this, that the surgery is computer assisted and not computer directed.
Hi, my name is Jen.
And here is a typical classical example. You cannot paint every canvas with the same brush. And have a look at this young lady.
My hip is a bit of an understatement.
This is a normal knee.
This is really my leg. It's not artificial or anything. I can move it around still. I can lean on it if I really want to. And I thought it'd be kind of fun to record reactions of everyone that I showed. So here we go.
So instabilities you need to take with a pinch of salt. What is the new challenge? What are we going to look forward to in the next decade? I think the challenge is the revision. It's the revision overload. Look at some of these, and the treatment options are available. They're costly, they're expensive, they're demanding, and they're fraught with danger. And there's a whole myriad of issues. This did the WhatsApp round. I'm not sure if that actually happened, but you can see over here, this is a completely flexed implant, the patellar button out, periprosthetic fracture fixed with a screw, medial collateral ligament cut, and malrotation. So there's a whole bunch of issues that you can counter with this. Somewhere along the line, I was privileged enough to join the Persona team, and we had some absolutely wonderful people that I had the pleasure and privilege to work with, some of the finest orthopedic surgeons from around the world. We wrote out a book in 2013, this released at the American Academy in Chicago. And along the way, we met some wonderful people. We met the Dalai Lama, Zora Sagel, Professor Holz, and some of my very dear friends who are in the audience here today. So it's been an absolutely fulfilling journey. But my biggest learning really was that to understand the basics, being critical of yourself and the importance of teamwork, and particularly to recognize failures, especially your own, and how not to ignore them. And you look at some of the ironies of life. This man, if you see in his little lapel here, this is a man called Robert Bernstein. He's a hair transplantation expert. Look at him. I mean, the ironies of life. So my take for you is follow techniques, not technology. Here is another patient, an uncemented Miller Galante, 29 years, and you can see here there's no demarcation, there's no polywear, absolutely pristine. Now you have the issue of metal allergies, and this is coming more and more into vogue. And we had this patient, which we did very recently, hardly about 5 days ago. And this patient we used an Oxenium knee because she was allergic to virtually all metals, including the electrodes that we were using for her ECG monitoring. So you have to have this in mind in patients with allergies. This is the postoperative radiographs of this patient. I think Albert Einstein summed it up well. If I have to be able to see further, it's by standing on the shoulders of the giants that preceded us. And we have gone from almost 6 hours to about 15 minutes. So what's our present position? We believe in CR knees. We do not resurface the patella. We prefer an unsymmetric mode and ideally the monoblock tibia. I do very strongly believe that long-term outcomes and survivorship is surgeon and technique dependent, and technology is merely an aid and one should not be a slave to it. So if you follow the whole issue, we have come the whole circle, and it goes back to what I learned from John Insull: restore balance, the mechanical axis and get your secure fixation. And a very recent article that is on the threshold of being published, a 30-year survival figure from the ISK group that reported 69% survivorship, a testimony to attention to details and basics. Finally, this is one help that we can all do without. You need to understand industry pushes you, learn your limits, understand your limitations, and what you don't want to do is to have help like this. And so, to summarize, to bring this to a close, we started in 1985 trying to cover knee surgery from start to finish, and our journey pretty much has been something like this. We are about at this stage right now.
And Aishwarya, thank you very much for accepting to do a opposite heroine character opposite to me. I'm not exaggerating. Bangalore, my brother's house is there, I went there. Nearby, one Rajasthani tenants, they have come there. After knowing that I have come, I was there, he came to see me. Some Rajasthani, his name is Nandulal. He is some 60 plus. He came and he said, kya baal sab kya ho gaya yaar? I said, jhad gaya, chodo. Kya retail life, mazak kar rahe kya? Abhi ek picture kaam kar raha hu. Acha, kaun si picture? Robo. Acha, good. Then I told him, Aishwarya Rai heroine. Aishwarya Rai heroine, kamal ka ladki yaar, fantastic. Aishwarya Rai heroine, hero kaun? मैं हीरो. Said, तुम हीरो? बच्चे लोग साथ में आए थे. Daddy, yes, he is hero. Daddy, he is hero. Then 10 minutes he was there. He didn't speak single word. He was staring me only. Then okay, चला bye. बाहर से आवाज आता है, अरे क्या होगा यार ऐश्वर्या जी को? अभिषेक बच्चन को क्या हो गया यार? अभी छोड़ रहे हैं. अमिताभ साहब को क्या हो गया यार? हीरोइन इसके साथ. So thank you very much, Aishwarya.
So I feel a bit like that. So finally, to wind up, we believe in togetherness. We believe that all you need is teamwork, even if somebody else has to put the bottle to your mouth. And I'd like to take this opportunity to thank the organizers and all of you for a patient hearing. Thank you very much.
Thank you, sir, for that very interesting talk.